evolution of the management strategies, or how we are where we are. And this is a talk which is very, very near and dear to me, very close to me. I'll give you the reason very soon. We all know that patients with degenerative spondylolisthesis with spinal stenosis, which is the major chunk of patients with spine problems, who do not respond to conservative treatment, do well with lumbar decompression and fusion. And I don't think there is any controversy about it. Kshitij very well defined what is the correct indication for the surgery. But what I'm going to tell you is a story of how we reached this conclusion as to why should we be fusing and decompressing this patient. And there's a lot that goes into it. As I said, this is a story that is very close to my heart because of my connection with Beaumont Hospital. A lot of the research work on lumbar degenerative pathologies happened at Beaumont Hospital, Michigan, and I spent a year here with the best of the minds in spine surgery. This is Harry Harkov, the guy who actually gave the original thought process in terms of why we should be doing what we are doing. And I was his last but one fellow. I think I'm one of the 3 Indian surgeons who's been trained with him. So let us see what we can share. This is more of a story. This is not a technique-based talk. We all know the investigations that are needed for defining spinal stenosis with listhesis. We need flexion extension films which can identify a lot of things which are not obvious on a supine MRI or a supine X-ray. There are investigations like CT myelography which are of historical importance, but we need it every now and then with patients who have a pacemaker or who probably is claustrophobic. You also have a lot of obese people these days. When we talk of treatment, we can think of conservative options. There are patients who just need decompression. Fusion alone may not be the greatest option. Decompression with fusion in situ, and instrumented, non-instrumented fusion. A lot of other options. A lot of options are available. And conservative treatment. Let's look at the role. Maybe you can try it for a couple of months. If the symptoms are progressive, then you have to move on. It involves physiotherapy, it involves use of neuroleptics, maybe NSAIDs, corset or a brace for that matter, core strengthening, injections, we all know of it. Patients who do not respond to these measures, we need to try some other options. So some literature about conservative treatment. The main study was a landmark study which looked at the role of conservative treatment, and what they found was only half of the patients were satisfied with this particular treatment modality. In another study done by Johnson's group, 70% of the patients did not have any relief. So the role of conservative treatment when you have a well-defined pathology with well-defined symptoms can be a bit tricky, and you really need to be judicious as to how much time and money you want to spend on these options. So surgical indications, persistent leg pain, claudicant or radicular type, you may have an overlap of the two. Neurological deficit, most importantly, it is about quality of life. American Heart Association suggests that every individual should be doing about 5 days of workout for about 30 minutes. So 30 minutes of walking is necessary if you want to live a healthy life. And if you are not able to do that, probably, and if it is because of the spine problem, you have a well-defined indication. And of course, your clinical picture should match with the imaging study. So surgical treatment options, you can either decompress in patients who are stable, who either do not have a spondylolisthesis or have a spondylolisthesis which is stable. It is rock solid, it is not moving. You can get away with a laminectomy only. But when you have a spondylolisthesis which is mobile, which is associated with back pain, the disc is really degenerated, then you are more inclined towards fusion. It could be a posterolateral or interbody fusion. The question that I'm going to elaborate on is how did we get to this point? And this is the study that we should kind of focus on, or we should start with. This was the landmark study that was published in the JBJS in 1991. This was a prospective randomized study. At that time, there was no concept of ethics committee, and Dr. Harkovitz just decided to randomize the patients on his own. So this was a big ethical issue, and JBJS actually kind of went a lot to and fro in terms of how could you do something like this, just randomize patients to one particular group on your own without taking consent. So he just distributed the patients in 2 groups, 25 each, and in one group he put in some bone graft, and in the other group he just decompressed. And I think this is a perfect study. This is level 1 evidence. It is not possible to do it because of ethical reasons. You cannot just tell a patient that you are going to the surgical group unless the patient consents. So it may not be possible to do this. And beyond 1991, the way of looking at studies and research changed completely. Beyond this point, JBJS started looking for an ethics committee approval when studies were being published. But he came up with some wonderful recommendations, and what he found was patients who had an attempt of fusion done did better better with their leg pain and back pain than the other group who just had decompression. Of course, the rate of pseudoarthrosis was much high in the non-instrumented patients. It was as high as 32%, and if we compare it with today's availability of good pedicular screw fixation, it is almost 24 times that of what we are achieving today. So the next kind of important study was Zadeblik, who looked at non-instrumented fusion versus instrumented fusion. Again, he had a number of different techniques that he used. What he found was rigid pedicle fixation gave you a very high fusion rate. So we have two thought processes going on. One is that if you attempt fusion, your symptomatic relief is much better, and if you do an instrumented fusion, you are getting a very good fusion. The next person who came into picture, again, Jeffrey Fishgren. He's again the same group, Beaumont Hospital. He was, I think, Dr. Harkovitz's third or the fourth fellow. He again decided to look better into this. So they started with 76 patients, and here they tried to do it in a more refined fashion. So they did just decompression fusion with autograft in one group, and they did rigid instrumentation in the other group. And this is Jeffrey Fishgren. He's the present chairman of the Department of Orthopedics. He's also the fellowship director. A very friendly and a smart guy. One of the fastest surgeons I have ever seen. And what they found was, although the fusion rate was different in the two groups, but the clinical outcome was not different. So at 2 years, we are looking at a situation where it does not make a difference whether you fuse the patient or not. And this caused a lot of confusion. They actually got the White Cloud award, which is a very well recognized award for their paper. So at 2 years, there was no correlation between the fusion and the clinical outcomes. And what they concluded was there was no improvement in the outcomes if you instrumented. And this was causing a lot of confusion. This was a time when pedicle screws were just on the horizon. They were being available. People were learning to use it. And you have a study which actually puts it on the back foot. And then there were other studies which came in. This was a Japanese study which again looked at the same problem, and their outcome was slightly different, but they were looking at a 3 or a 4 year outcome. So they actually felt that there was a difference as far as the outcome when you could achieve some amount of fusion. Then again, this study in spine looked at the fusion rates with instrumentation versus non-instrumentation. With all these things happening, again, the Harkovitz group decided to have a relook at the patients that they had studied for the White Cloud paper. So the same group of patients, the 76 patients that they had studied, they tried to follow these patients up, and they looked at the 7-year follow-up. And that is where they actually realized that there was a big difference in the two groups. So at 2 years, both the groups were doing more or less the same, irrespective of whether they were achieving fusion or not. But as time passed by, the good results of the decompression started deteriorating in patients who did not have a fusion, while those who had a good fusion had excellent result. And you can see the difference in the outcome. Solid fusion, 86% excellent outcome, versus the pseudoarthrosis group, almost 50% of them are unhappy. And that was the decider. So when you are looking at long-term outcomes, good instrumentation and fusion makes the difference. And this was the landmark paper. Kornblum was the fellow in 2004. So the legacy kind of continues in terms of understanding the pathology. And I think it is appreciable that the dedication of the group in identifying a problem and trying to go to the logical conclusion of this problem. Now, these thought process, this particular thought process was very well kind of validated based on the sport study, which is one of the biggest and the best study that we have to look at the outcomes of spine surgery. And what did they find out? They looked at the non-surgical versus surgical treatment of spondylolisthesis, in which the unstable spondylolisthesis were offered decompression and fusion, and what they realized that the patient who were treated surgically showed a substantial greater improvement in the pain as well as the functionality at 2 years. And the next study, again, the same group, published in JBJS, level 2 evidence, patient treated surgically maintained the good outcomes of pain relief at 4 years as well. So it's kind of a continuum of a thought process which gives us an understanding of why fusion is necessary, why fusion matters, because it can change the outcome in the long term. So the take-home message here is that decompression is key to achieve relief of symptoms in the short term, because patient presents with claudication. Typically, patients do not have any significant back pain to begin with. Fusion maintains the improved outcomes in the long run, and instrumentation, whether it is posterolateral or interbody, improves the rate of fusion, and that is the reason we are offering the patients decompression with fusion. This is Royal Oak, Beaumont. I spent a year here. I had to walk through a lot of snow. I used to live in one of the corners on the left side, but I enjoyed the time there. So it was fun to work with some original minds in the field of spine surgery. But having said this, have we solved the problem? Once we achieve the fusion, it just does not kind of end the problem. You start with a new problem, that is adjacent segment disease. Hopefully we can talk about it in the next CCOT, but till then, thank you for your attention.